Hello there, I'm Dr. Well with Pete's Happy Hearts, a heart clinic for kids. School is about to start and sports pre-participation screening is underway. Today I would like to talk about sudden cardiac death in athletes, importance of adding ECG and echocardiogram to the sports screen. This video is to provide information and opinion. It is not medical advice. For specific individual questions and concern, please discuss with your doctor. Sudden cardiac death in athletes is tragic, especially when it can be prevented. Currently, the American Heart Association recommends a 14-point evaluation for sports physical. It includes questions on symptoms and family history, measures of blood pressure, height, and weight, and listening to heart in multiple positions. It also looks for any stigmata of Marfan syndromes. If they're concerned about medical history or exam, then an ECG or an echocardiogram, also known as TTE, is performed. I have attached a link to the sports physical form in Montana if you're interested. So what are the common causes of sudden cardiac death in athletes? It can be broken down into a few groups. One, heart tissue abnormalities such as hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, myocarditis, or congenital heart disease. Two, disorder of the electrical conduction system. This can be with Parkinson-White syndrome, long QT syndrome, or ventricular tachycardia. Three, coronary abnormalities, such as anomalous origin of the coronary arteries. Four, heart valve disorder. Five, disorder of the aorta. The argument to include electrocardiograms, also known as ECGs. So multiple research has shown that the American Heart Association recommended detailed history and physical, also known as HMP, which is inexpensive, has poor sensitivity, as most athletes are asymptomatic. Thus, the HMP only identifies a minority of those athletes at risk for sudden cardiac death. From William et al., overall, the 14-point evaluation performs poorly with the ECG for cardiovascular screening of athletes. USA and Europe differ in their evaluation. In addition to the HMP, ECGs are part of the European screening. The reason comes from the research in Italy. Italy started implementing the ECG mandate in 1982, and it showed almost a 90% drop in sudden cardiac death in their athletes. European Society of Cardiology recommends including the ECG with the screen as it improves sensitivity for detecting serious cardiac disease. In Italy, ECG is not recommended, but is mandated by law. There is little question that ECGs vastly aid in screening young athletes for sudden cardiac death. A meta-analysis by Herman et al. Showed that compared to HMP alone, adding ECGs to screening is 6 times more likely to detect a cardiovascular condition associated with sudden cardiac death than without. A study at the University of Washington, which is sponsored by Nick of Time Foundation, showed that American Heart Association 14-point evaluation does not appear to identify a subgroup of athletes at a high risk of underlying pathologic cardiac disorder. In contrast, the study suggests that 1 out of every 7 athletes flagged with abnormal ECG will have a condition associated with sudden cardiac death. This study comprised of 3,620 student athletes. Of those patients or athletes, 16 had significant heart condition, which is about 0.4%. 9 athletes had with Parkinson-White syndrome, 3 had long QT syndrome, 2 with hypertrophic cardiomyopathy, 1 with dilated aorta, and 1 with anomalous origin of the right coronary artery. The 14-point evaluation was flagged as abnormal in 7 of the 16 cases, which is 44%. The ECG was flagged as abnormal in 15 of the 16 cases, which is 94%. There was no athlete identified with a cardiac condition associated with sudden cardiac death solely from abnormal physical exam. So if we were to use the AHA 14-point evaluation, which the patient has to have positive questionnaires and abnormal physical exam to move on to the other cardiac testing with the ECG and electrocardiogram and echocardiogram, 9 of the 16 cases would remain undetected, which is about 56%, which includes 3 with Parkinson-White syndrome, 3 long QT, 2 hypertrophic cardiomyopathy, and 1 dilated aorta. Now, if we were to use the ECG as the only screening tool to trigger further cardiac testing, only 1 of 16 cases will remain undetected. That would be 6% and is from the anomalous coronary artery. So why should we include transthoracic echocardiogram, which is the TTE? So TTE is an ultrasound of the heart with images taken from the chest. It is non-invasive. It has many application and added tool. There's a little uncertainty in the echocardiographic findings for bicuspid aortic valve, valvular disease, disorder of the aorta, pathologic cardiomyopathies, and congenital heart disease, especially with a well-trained person interpreting the study. For example, echocardiograms in competitive athletes with ECG suggestive of hypertrophic cardiomyopathy can appropriately guide further management. While not typically included in most echocardiographic protocol to look at the coronary arteries, it definitely is possible and could supplement existing cardiographic studies. Of note, identifying coronary artery is part of the pediatric cardiology protocol. While the USA AHA is debating recommending 12-lead ECG to the sports screen, major international sporting federations have mandated ECG and echocardiogram for their athletes, which is highlighted in red in Table 3. Different tests aid in the diagnosis of potential causes of sudden cardiac death. American Heart Association 14-point evaluation raises suspicion of cardiac concern if there are cardiac symptoms or abnormalities on exam. Then it leads to a cardiology referral. ECGs look at the electrical system. Depending on the heart condition, it can be abnormal. However, it can also miss abnormal coronaries, dilated aorta, and early cardiomyopathies. Echocardiogram looks at the structures and can pick up abnormalities that the ECG miss. So why the US has not recommended adding ECG and TTE despite the data? The debate continues. Despite its clear superiority over traditional screening, several arguments exist against widespread ECG screening. So arguments in favor of ECG is the 12-lead EKG is non-expensive, it's largely available, has proven to be more sensitive than H&P alone. It is abnormal in more than 80% of individuals with cardiomyopathies or myocarditis or rhythm things. There has been a notable decline, about 90% of sudden cardiac death among young competitive athletes after implementation of the nationwide Italian ECG screening program. Arguments against ECG: the evidence of survival benefit of ECG screening is limited to a single observation study. Highly trained athletes may develop ECG abnormalities mimicking cardiomyopathies. Misinterpretation of the ECG is not uncommon and can lead to more expensive testing and workup. Some of the cardiovascular disorders, such as Marfan syndrome, premature coronary heart disease, or congenital coronary anomalies, are not picked up with ECGs. False positive can lead to a high number of workup and that jeopardize costs. And abnormal ECG can disqualify athletes. Now, arguments in favor of echocardiogram is the heart is seen in real time, the structures are seen, the valves are seen, the coronaries are seen. It has higher sensitivity, it's non-invasive, and it captures things that ECG and H&P can miss. The reason against getting an echocardiogram is, one, its cost effectiveness. There's limited human resources to actually get the imaging. The potential downside consequences of a false positive. So what's next? H&P with ECG is more sensitive and specific than H&P alone, as it can pick up more abnormalities. Echocardiogram can evaluate structures and coronaries which ECG cannot. Most competitive athletes are asymptomatic, so getting screening with ECG and TTE, or which is ultrasound of the heart, is essential. So what can parents do if they don't have access to ECG or TTE? They should ask their child about chest pain, shortness of breath, irregular heartbeats, fainting with exercise, family history of members with heart condition less than 50 years of age, history of Marfan's or connective tissue disorder. Further evaluation is essential if the child's cardiac exam is abnormal. Talk to your doctor about sports screen and specific concerns. If you want to make an appointment with me, contact me at hello@pedshappyhearts.com or visit my website at pedshappyhearts.com. If there's any topic you would like to hear about, please leave me a message or comment below. If you find this video helpful, please like, share, and subscribe to this channel. I look forward to seeing you guys again in the next video.